think we'll go on to the the most underutilized modality of all the modalities in foot and ankle is ultrasound. And I think it is, as the discussion is coming out, it is a very useful tool in the hands of both the radiologist and the orthopedic surgeon. So to talk more about that and to open our eyes on that is Dr. Raghav Agarwal, who's a specialist MSK ultrasonography, and he's past vice president and secretary of the Indian Radiology Imaging Association, and he's a very experienced ultrasound, fourth generation of radiology in the family, and he's also a very active member of the Delhi Medical Council. So, and also I must add that he's a very dear friend and what you call is a Langotia Yar, so from the beginning. So thank you, Raghav, for being here. And I would request you to present your talk on the ultrasound.
Thank you so much, Maninder.
Thank you.
Thank you, Maninder, and I am batchmates from MAMC 1991. So that is an introduction, and thank you for the Foot and Ankle Society. And I'm quite comfortable and proud that I'm sharing this platform with Dr. Daftari and Nafisa, because both of them are one of the top line MSK ultrasound people in the country. So they would understand, and they, as Nafisa has already, she's shared that, what is the, can we see my slide?
Yes, we can.
Yes, we can.
So my point is that, I'll just talk a few things about the ultrasound, the basic technique, and just go ahead. Because ultrasound is something like vodka, you can have it neat, you can have it with lime juice, you can put it in a cocktail. It will fit in everywhere as a standalone modality, as an adjunct, where you have the X-ray, we don't have the X-ray. There are obvious advantages of the ultrasound technology, that the cost factor, the patient tolerance. We can, do the ultrasound on field. We can do it in the emergency room, and what we call as a dynamic examination. We can actually see, as Dr. Daftari said, that how a tendon, a ligament, or a structure, which we can see is, how much is the susceptibility of that structure. We can do a dynamic examination by moving a structure, and we can do a dynamic examination by moving the transducer. Also, very importantly, that there is no contraindication for ultrasound, and you can do it in absolutely every condition. A pregnant lady, in the emergency, with implants, without, just simply everything. And more importantly, for therapeutics, I think all of them, including Dr. Nafisa and Dr. Daftari, will be using ultrasound. So ultrasound as a primary modality for diagnosis in the emergency room, with or without the X-ray, with the MR, will always add to something. And so many times I get post-MRI referrals, as Dr. Nafisa said, that sometimes we require the ultrasound, and but the ultrasound is like a gun. You have to be trained how to shoot it. And if you're not trained, then you might, land up in calling a pathology as normal, and vice versa. Also, the ultrasound normally is used as a segmental approach in the foot and ankle. We are mostly as a problem-solving technique rather than a standalone technique. But ultrasound, as it has evolved over the years, it has gone from MSK ultrasound started way back in the 70s, then MR took over. Then, the rheumatologists and the orthopedics kept it for us, and then the radiologists learned it. And as it is generally as an adjunct, and we get referrals from the MSK ultrasound for the foot and ankle from the rheumatologist, from the sports consultant, and the orthopedics. And it is generally an adjunct to MR, to skygrams, to the CT scan. It can be following them, it can be preceding them. And it has a pivotal role in therapeutics. In all these conditions, maybe PRP therapies, giving steroid injections, barotage, or following all pathologies which have been diagnosed on any other imaging modality. So a few slides about the technique. That anisotropy is a technique whereby we can actually see how a tendon works. We just skip through all this because we are already late. And then we need these fancy probes. We just need a matrix probe or a good probe which shows tendons, because with the correct probe and the correct settings, the pathology will show up better. And ultrasound has a higher resolution than MR on the structures which can be visualized. What I cannot visualize is anything below an intact healthy cortical bone. What I can visualize is anything above that. So in the ankle, anything above the joint and the bone will, whatever is accessible with the ultrasound will always add to the information which has been acquired from the other imaging modalities. So adding to it, the Dopplers are useful in pointing out the inflammatory process and the vascularity. Dopplers are useful in the superficial aspect. In the foot, it is quite useful. The other things which are started using is contrast studies for inflammatory arthritis, and contrast ultrasound I have tried and it has been useful in these conditions. Elastography again with the newer machines is useful. Just to show a glimpse that the ultrasound is not just the ultrasound which we are using as a basic pathology to look for collections and doing, diagnosing that there is a bursa or non-bursa. We have advanced a lot further, and it always complements these imaging modalities. A few words about the injection techniques. We have the in-plane, out-of-plane injections and using the jelly standoff techniques. And the ultrasound is the only modality which is, as an office OPD procedure, will actually pinpoint the area where your injectate is being injected. So just a glimpse of what the ultrasound can actually do for you. Diagnose the pathology, diagnose the tear, or in this case, the inflammatory arthritis, show the inflammatory process, guide your injection. And here you can see if this is a rheumatoid arthritis patient where we had a exuberant synovial hypertrophy, how we could actually, this is a previously failed injection, and then when we are injecting, we are actually, the ultrasound is precisely taking you to the point where we want to inject. So this accuracy, this resolution is not possible with any other modality. A few cases I will try to cover and try to, just show what we can also see on the ultrasound. On the ultrasound, we would be able to see the extensor tendons, the tendons of the tendon in the tarsal tunnel, the peroneals, the tendoachilles, the plantar fascia, the joints in the superficial aspect, looking for the collections, effusions, evulsions, ganglion cysts, any tumors, superficial aspect. But in any case of a tumor or a pathology which is looking more like a malignancy, the MR would always be preferable. But for the aspirations, biopsies and FNACs, the ultrasound would be the modality of choice. In the ankle, we would normally access the extensor tendons, the anterior. This was a patient of ankle pain. So, plantar fascia region pain. We could have done the focused ultrasound, but we just generally want to screen the other parts. That is what we do, the extensors, the anterior recess, the middle recess, the tarsal tunnel, and looking at the tendoachilles, you can see this is an old image. You can see still with the previous resolution scanners, we could see the tendoachilles and the fibrillar pattern of the tendon very beautifully. And we can compare here and how beautifully we can see simple clinical scenarios like plantar fasciitis and thickening of the plantar fascia along its calcaneal insertions, which is a very common pathology. This was a patient with plantar fasciitis, again with minor tears, partial thickness tears here. The ultrasound was a good enough pathology combined with the skygram. The X-ray is done and we see the calcaneal spur, which has its own logic and limitations. But the ultrasound certainly adds to, clinching the diagnosis. MRI would be useful in other scenarios where there's additional pathologies. Coming to inflammatory arthritis, the ultrasound is the modality of choice. We would be easily seeing and if you are correctly trained and you know how to see the erosions, we would be seeing the erosions almost as well as we see in the MR. And then we are looking at the superficial aspect and the inflammatory synovial hypertrophy and the synovitis in the ultrasound. This was a patient of inflammatory arthritis also showing paratenosis. This is how you can see classically the paratenosis and a tendoachilles on the ultrasound, the hypoechoic thickening with vascularity along the peripheral superficial aspect of the tendoachilles. This patient also had a tenosynovitis. Again, the ultrasound would be the modality of choice for diagnosing tenosynovitis and doing the injection processes. This was a patient of injury. In the emergency room, the skygram was done, and this was a calcification which was not picked up then. And you can see how the ultrasound is useful in telling me about the edema, the hematoma, the evulsion of the tendoachilles with the Kager's fat pad impinging and the donor site of this evulsed segment. So I think a modality like this immediately would tell the clinician that yes, this is a surgical case and this thing can be done in the emergency room itself. And adding one more point, as Dr. Daftari said, that we as radiologists have to learn to be clinical radiologists, and we have to answer the clinical question which the orthopedic surgeon has asked. So if my clinical question is that there is an instability and I'm going to answer it on the ultrasound, the choice of the ultrasound should be the first one and then the MR. Or if the MR has been done, we want additional information, the ultrasound could be the modality of choice. This was a patient with, again, with ankle pain, and there was the X-ray showed an enthesiophyte formation, but the tendo-Achilles per se was fine. The patient had got a new pair of shoes and a foot bite, as you call it, classically diagnosed on the ultrasound as effusion in the tendon sheath, and changing the shoes with just a 20 mg steroid shot was good enough in this case. This is a patient again of tendo-Achilles, as I think Dr. Nafisa had said that for the tendo-Achilles, ultrasound is an excellent modality. We can see a hypoequic tear here with inflammatory vascularity along the superficial aspect. So the ultrasound, we can actually see a tear and do a compression, decompression, and actually see whether it's a tear or a tendinosis there. Additionally, the MR might be useful, but it has to be a cocktail of investigations which can just answer the question asked there. Again, we can see retro-Achilles bursitis here. The ultrasound again will clinch the diagnosis and show you how much the inflammatory process actually is in place. So I'm just hurrying through and just showing you the images so that we can discuss later. Again, a patient of retrocalcaneal bursitis, tibialis anterior tenosynovitis. Again, this was an indeterminate inflammatory arthritis patient where the ultrasound could pick up most of the inflammatory findings and the erosions here. A patient, this was a sports person showing a calcific tendinosis. So on the ultrasound, I could diagnose these tiny sub-millimeter calcifications. We could do a barbotage for them, maybe in the same sitting or in the discussion with the orthopedic surgeon, or follow-up, or we could follow them up because the MR might not be too useful in showing these calcifications, so tiny calcifications. This was a foot, plantar fascia pain patient in which we had a angiomatous malformation, and we could see a painful nodule with a lot of vascularity. The video is not working here. So the ultrasound is quite useful in plantar fascia for foot and ankle pain syndromes and inflammatory pathologies. And coming to ligamentous pathologies, as my colleagues had said, for the ATFL, the ultrasound is, I think, the modality of choice. And here you can see what we had discussed. We can compare the left with the right. So here we can see the right ATFL beautifully, and on the left we have edematous, wavy ATFL. And at the same time, we can test the integrity of the joint, of the ligament. We can see a bulky ligament here, but the amount of ligament left around is almost 1/4 of the bulk of the ligament. We do the grading also in the ultrasound, and we can follow up on whatever has been done in the other modalities. So the ankle ligaments, especially, we can look at the larger ligaments, we can look at the intertarsal ligaments, the anterior inferior tibiofibular ligaments, ATFL, calcaneo fibular ligament. Again, the MR, my colleagues would agree that the calcaneo fibular ligament is a very tricky ligament to examine. And with the ATFL injuries on the ultrasound, with the edematous calcaneofibular ligament or a torn ligament, we could actually pick it up very well. And also at the deltoid ligaments, though may not be very easily assessed on a normal deltoid ligament, but whenever there is a pathology or a tear, we would normally pick it up on the ultrasound. So this is a bouquet of ATFL injuries which we would normally see. We might pick up a avulsion fracture there with a thickened edematous ATFL. We might pick up a re-injury, because in these cases the MR would be slightly tricky, and a sports person or a person who's had an injury of the ligament, the ATFL, would have to tend to have a re-injury. Here we could see old avulsions and maybe calcifications with edematous tendon with vascularity. We can have a grade 2 injury where a thickened tendon with vascularity but intact, just an old avulsion, no tendon there. And also when we are seeing the ATFL, we can also at the same time see the calcaneofibular ligament. Here we can see On this slide, this is a crowded slide, but here you can see on the left side, the left calcaneofibular is absolutely fantastic. In the right is a edematous thickened calcaneofibular ligament. So we can compare the left with the right and we can see it there and then. This I just shared. Same anterior draw to the ATFL assessment, the dynamic assessment. And at the same time, when we do the dynamic assessment for the calcaneofibular ligament, doing a dorsiflexion, it would just pop up and the peroneals would just come out. Whereas a normal tendon, you might not see it, but you just see that the tendons, the peroneal would just pop out and you could see it. So you can see how useful and how easy, it is just like magic when you just see it, and then it does take a lot of time, a lot of trust for the orthopedic surgeons, because orthopedic surgeons are not a breed which can be which will trust you. But once they trust you, they'll trust you blindly. Again, you're looking for fractures, injuries, avulsion fractures, fracture healing, and just a few slides about inflammatory arthritis, because I also work with the rheumatologists. So we would be doing assessment for inflammatory arthritis, assessing for synovitis, erosions, and tendinosis. Then doing a dynamic examination for looking for erosions, as in this case, and all pathologies in MSK ultrasound, be it tendon pathologies, injuries, or tears, have to be demonstrated in two perpendicular planes. Flexion. This is again a dynamic examination showing you synovial hypertrophy with effusion in small joints of the foot. Rheumatoid arthritis, all aspects of the disease seen on the ultrasound. Gout. On the ultrasound, we have this classical double contour sign, which is a sign of hyperuricemia. But in this particular patient, the metatarsophalangeal joint was showing a double contour sign along with the synovial hypertrophy and synovial proliferation and Dopplers. So we could tell you whether the dual energy CT will tell you that there are tophi. We can tell you the tophi in the ultrasound. We also have this double contour sign, which is a very, very specific sign for hyperuricemia. And we can pick up the associated inflammatory pathology and associated activity of the gout as it is seen in this case. Psoriatic arthropathy, again, the feature, this is a slide of the hand, but we can pick up similar findings. And again, osteoarthritis. Here you can see in osteoarthritis, we have these step up artifacts. We have a step up artifact here. In inflammatory arthritis, we have the erosion step down artifacts, and a fracture will be a step off artifact. So when we are looking at a structure, maybe a secondary osteoarthritis in a joint, but when we are looking at a structure with osteophyte formations and joint space loss, we know that we are dealing with a degenerative joint. So I just trying to finish it off, my last slide, that except for bone edema, ultrasound would be practically picking up everything in the ankle. It's a grossly underutilized modality, and it is complementary to any other modality. It will just fit in very comfortably with the other modalities. And with all its advantages of patient acceptability, being a non-ionizing modality, no contraindications, cost effectiveness, being quick, being of therapeutic use, and we have the other newer modalities, I think ultrasound is indispensable for musculoskeletal pathologies in general, and specifically in foot and ankle, where we could do dynamic examinations and also do therapeutics along with that. I think with that, I will end my presentation.
Thank you, Dr. Raghav. I think you've hit the nail on the head. There's an excellent presentation with lots of interesting cases. I was at slightly loss because us as orthopedic surgeons, our eyes are not trained to look at these ultrasound images, and which structures are which is sometimes difficult for our eyes to discern. We are more comfortable with MRI and CT images, and that's why I think that bias is there, that we have to rely completely on our radiologists to actually understand the ultrasound images. But you are absolutely right that, Yes, Shanta, please.
Yeah. As you rightly said, it was indeed an eye-opener, because most of the time I would rather advise MRI, but today I can see, although, let me tell you, in my MS, shoulder ultrasound was part of my thesis. But yes, as you showed us, those simple injections can be given in MTP joints. And dynamic examination is something really we look forward to. We are really thankful that you've given a wonderful presentation and opened our eye to entirely new world. Thank you so much.
Let me tell you, even Dr. Nafisa and Dr. Daftari are one of the best people in the ultrasound. So.
And your comment about orthopedic surgeon is spot on, that we generally don't really trust, but when we trust somebody, we really trust blindly. Thank you so much. And this applies to my radiologist also, who probably is watching as well. So thank you so much.
Thanks. Dr. Nikesh, you want to?
Yeah, Dr. Raghav, we have a few questions from delegates. I'll be fast. How to differentiate between tear and the tendinosis on ultrasound with tendo?
By the time the patient is coming to me, most of them have got MR also. And on the tear, the tear would become look hypoequic or maybe anechoic. A tendinosis is generally hypoequic. We could see vessels around the inflamed tendon or the tendinosis. We could see vascularity within the tendinosis, but a tear would not show you any vessels inside. Plus, we can do a compression examination. Just do a forceful compression decompression. A tear will be compressible. A tendinosis will not be compressible. Tear will generally be less painful also.
And you have shown in your slide the huge amount of jelly, and on which you have put a USG probe, and through jelly you were injecting with the needle. So I have two concerns regarding the sterility part of it, and what is the technique behind that, or what is the logic behind it?
That means that you have seen my presentation. Thank you so much, sir. It was a inside slide. Very, very easy technique. First thing is that we have to use sterile jelly. There is no shortcut. Sterile jelly is available in India. If you are using a jelly standoff technique, what we are doing with that technique is when we are doing MSK injections, most of the times what is happening is that there is a blind area. We do an entry point and we track the linear, how the needle would go inside, and then we would inject. But when we have a very superficial structure and we have nerves there, or we have structures we want to avoid, using a jelly and doing a triangulation, I would make the needle track more parallel. So I can examine and inject in a long axis instead of a short axis. And what I do when I do that, the jelly, should I show you in the slide? If you want me, I can just show you in the slide that, what happens is that we make the, needle parallel to the probe. So at all times when the needle is parallel to the probe, our visibility is always better. And we actually know that where we are injecting. So here we can see that, we plan in a way that the needle becomes, it is going parallel to the probe.
We can't see your, we can just see we can't see your slides.
You can't see the slide. Okay.
Maybe a double click.
Now?
No.
We can just see
your
your desktop.
List of slides, list of folder, ankle
pathologies.
I think I'm...
Raghav, you need to go back to share your screen and change to the screen, the other
Choose
screen.
the different one, yeah.
Yes.
So I think I've...
This folder.
I think I'll rejoin. So...
Not rejoin, but yeah, just stop share.
Yeah. Now,
yeah.
So...
While Raghav is doing this, I wanted to just loop back to that question about tendinosis. Could I continue?
Yes.
Yes, please.
So, well, actually, ultrasound is possibly the best modality to differentiate tendinosis versus tear versus tendinitis. And one of the reasons for that is that in ultrasound, we can actually see the fascicular nature of the bundles of either ligaments or tendons, whatever we are seeing. In cases of tendons where you see each of those fibrils, you can actually see that fibrillar structure on ultrasound. And whenever a tendon loses that perfectly fibrillar sort of echogenic lines through it, If that's not there, if it's heterogeneous or if it's bunched up or it's thickened, but loss of that fibular structure is a surefire way of saying that this is tendinosis. In a case of tendinitis, that fibrillar structure will be preserved, the tendon will be just swollen. In a case of a tear, again, it will be preserved at places, but the tear will show a disjunction and you'll see fluid seeping through it. And at times, the tear can be interposed on a tendinosis. So there's already heterogeneity, is already looking non-fibrillar, and on top of that, there is a tear.
Thank you so much. Thank you.
So can we say safely that if we have a suspected tendon injury or tendinitis, is ultrasound the first modality of call? And if we suspect no other pathology in that patient?
Yeah, sure. As long as the tendon is superficial and it can be seen well, yes. I mean, it's one of those tendons that you can't see well on ultrasound, or it's deep, or it's difficult to image, like an adductor longus when we are looking at MRI groins. I mean, I'd be able to see somebody else's adductor longus with skin. If it's a big guy, I'm not going to be able to say that there is calcific tendinosis of the hamstring origin or the adductor longus. But something like a tibialis posterior, it's too simple, and MRI is an overkill.
Okay. So do you think we should try and learn ultrasound for ourselves as well? Would you train us? I think, and because to send the patient down for an ultrasound, as I said, ultrasound is such a portable thing that you want to just do that in front of your eyes, and to actually come down is the main hurdle, because we can't see the images, so we don't get that feedback. So I think really, I think we have to come down to your place to learn the ultrasound from you, and then I think that will be. I think that's what we have to do as foot and ankle surgeons, is really learn what all we can. Because I went to Raghav that just a week ago, and he showed me structures in the foot and ankle which I'd never seen before. So well seen on ultrasound. So I think it's really really an eye opener. As Shantanu said, it's an eye opener that we can use ultrasound much more in foot and ankle.
Ultrasound is the stethoscope. Is the surgeon's stethoscope.
Yeah,
We all should be able to do it.
You are spot on.
Ultrasound examination.
Yeah, Maninder, you are spot on, because let me tell you, just the other day I'm planning to buy the Sonosite, and today's presentation has really strengthened my resolve to learn and buy and do a little ultrasound, maybe small ones at my own clinic, probably.
So I have a view on that, actually, and everyone is welcome to do whatever they want. But my view on this is that, first of all, I find that in my experience, I've seen a lot of orthopedic surgeons are completely driven by their clinical opinions. Okay, so you're clinicians at heart and at everything. So when you go and do an ultrasound, you say, I want to find posterior tibial tendinosis. I want to find a posterior tibial tendon tear. And ultrasound is a modality where you can make anything look like anything.
Okay.
So if you are in that frame of mind where this is what my diagnosis is, it's a big learning curve. So by all means, I think learn. I think you will stand much greater. It's for me the same thing. Tomorrow somebody comes to me with ankle pain and it's come from somebody the other from wherever. I know that this is ankle impingement. I know that I can inject them. I know I can do a nerve injection. I know I can do 14 other things for the patient. But let us respect each other's boundaries, what our strengths and weaknesses are, and let us try and support each other rather than eat into each other's work. This is just my opinion. And you're more than welcome to do whatever you want, as I said. But you will learn the hard way. And there are enough pitfalls that come with clinical bias and doing ultrasound with clinical bias, for sure.
I think additionally, there is a medical legal aspect to it as well. I don't think it is really, one can keep a ultrasound machine in his OPD setup. I think the radiologist can guide me better on that. With the MTP Act and other things, I don't think in India it is legally allowed to have to operate an ultrasound by a non-radiologist or a non-gynecologist, as far as I know.
Great.
There is supposed to be a training process, and you have to get your PNDT approval in order to do that.
Yeah,
so
Absolutely.
And also there's a lot of headaches that come with the PNDT. So even a cardiologist who's doing echoes only has to go through like a full PNDT clearance process and documentation of everything all the time. And if you don't submit the documents by mistake in a month, then the local body can come and just shut your machine down.
Yeah, there's always a right way and wrong way of doing things. So I think there is no deterrent, Shantanu. You can train yourself properly and use it. What the point was that we shouldn't just try and just because a radiologist does it well, we will be able to do it well. But if a radiologist can do it, I can also train myself and train it properly, do use all the legal things. It's a nice tool to have. Even in the ATLS training today, they say that you know, the probe is such a good thing that you can check so many injuries right in the casualty, like a focused examination of a trauma. So it's going to change. A few things are going to change over a period of time. The domains are going to overlap, which has been happening in medicine for so many years. So I think there's nothing wrong and right as long as we follow all the legalities and we are in the safe way. We should be complementary to each other. So we will not be competing with you, but we'll be complementing with you. That's what we.
I hope
Yeah, no, absolutely. I mean, that's the point.
You were
Exactly.
spot on. You just said it the right way. Yes, we can be complementary, and it never hurts to learn something. So that's what we had discussed when we had met recently. Yes, so there is indeed a learning curve, but we should sometime learn new boundaries also. Thank you.
Of course.
So I think that was a great, I think everybody learned a lot really from your talks. The
Absolutely.
X-ray, ultrasound, CT, and MRI. I think we saw new pathologies, new things today that we didn't know about before. So I think that was a great. So I'd like to ask Dr. Mahinder actually to give the closing comments, and if there's any other questions.
Thank you. Thank you for the privilege.
Thank
I
you.
think this was one of those sessions which is really experienced faculties. I mean, you have really opened the eyes, the surgeons. We are always proud of our clinical, acumen. But I think when it goes beyond that, we realize how much we have not seen, and a good radiologist can really help you. So I think thank you, thank all the faculties for spending their Sundays with us in teaching, and also to Dr. Maninder and Dr. Nikesh Bhai for excellent moderation. And we should interact more and more in order to get better. I think it's all about putting both the clinicians, the radiologists and the orthopedic surgeons on the same floor very frequently so that we can learn from each other, and it helps each other in our individual practice, because the more we interact, the better we get at diagnosis. Thank you very much.
Yeah, before you finish, it is my solemn duty to appeal to all my IFAS members and everybody else and remind them that we have our annual conference, IFASCon 2021, in the last weekend of August in Kolkata. The organizing secretary, Dr. Abhijit Bandyopadhyay, and his team is leaving no stone unturned in making this the most memorable IFASCon. So I'll appeal to all my members to ensure their participation in IFASCon 2021 Kolkata. Thank you.
Thank you, guys.
Thank you.
Thank you.